to distribute also in case there's something that you missed and you'd like to hear it over again. I know a lot of people do like to replay sometimes the webinars. So today's webinar, again, it's great to be joined with our health partners. Again, I'm the Interim Chief Operating Officer at the Community Action Partnership. We're a network of 1,000 plus community action agencies. We are commemorating our 50th anniversary, being formed from the War on Poverty and the signing of the Economic Opportunity Act in 1964. Our network is a diverse group of nonprofit and public entities serving 99% of America's counties. We are required by statute to conduct community needs assessments every several years and use the results of those needs assessments to decide what services and programs and activities need to be done in the community, both with services for families as well as macro change and changes in community efforts. So partnering closely with the health community is certainly something our network has a lot of experience with, and vice versa. And we're pleased to highlight today a lot of the intersects, both between what community action is doing around some of the social determinants of health and the work of the health community in terms of assessing health disparity, health equity issues, and how can we work better together to help families and help communities thrive across our country. I'm going to turn over briefly here to Dr. Adini, who is the NPA lead for the Office of Minority Health at the U.S. Department of Health and Human Services, to give us a bit of her vision and context for today's webinar. Adini?
Thank you very much, Denise. Good afternoon and good morning, everyone. I want to spend the next few minutes just providing you with the goal for this presentation and also talking about the context, background, vision that we have for this conversation that we hope will start with this presentation. The purpose of this webinar is to initiate a discussion about how we can strategically align the resources that already exist to provide community benefits and services. In other words, how can we better target or perhaps pool these multiple resource streams that are available in communities with multiple needs? This is a very important topic because we work on health equity, we work on population health, and change is necessary at all levels to advance national health equity goals. We need to change systems and how these systems might promote health within communities or how they can work to prevent or eliminate health disparities. We also need to work at the community level to change the conditions in communities, and that's where organizations like the Community Action Partnerships and the National Network of Public Health Institutes come to play. That's where their work becomes so important. We also need to work on the individuals. There are some things that we can do with individuals, but for today's conversation, we're focusing on the work that can be done in communities. The communities we work with traditionally have high burdens of disparities, and they have these high burdens of disparities because they have a convergence of multiple deficiencies or issues. So we're talking about communities that suffer deficiencies in, say, housing, access to healthy foods, and other social determinants of health. Therefore, the ideal solution suite should be comprehensive, or 360, if you will. We should be able to, at the same time, talk about housing, talk about healthy food access in this community, talk about employment, education, and all the other social determinants of health that might be an issue for any one community. So the good news is that we have a number of entities like the Community Action Partnerships or the Community Action Agencies, as the individual agencies are called, that are charged with implementing programs to improve well-being and health in these communities. And then we have entities like the National Network of Public Health Institutes that are also doing work on health. So there's a lot of opportunity that we can leverage here. Perhaps the added value to the status quo, to how we do business, is that essential component of coordination at the community level from the assessment phase. So many of these groups are required or mandated to do assessments through the design and execution of implementation plans is what we bring to the table. Each entity has its own mandates, like Denise mentioned earlier. They have their own systems of operation, they have processes that are in place, and they have their own conversations about the issues that they have purview over. And these issues are, of course, about community needs and the types of benefits and services that can be provided to address these needs. So that is why this coming together of these different minds is so essential, and that's why this discussion is absolutely necessary. We do look forward to a time in the near future where the variety of benefits and service providers in communities can convene and begin to strategically chip away at a comprehensive list of community problems. So that's why we're here today. I'm very excited. You're going to hear some excellent presentations from Drs. Wicks, Lufthansa, and Rodini. I want to thank Denise Harlow, Andy Cruz, and Erin Marziale for working with us to make this webinar happen. And I look forward to the discussion session of this webinar. Thank you very much. Denise?
Thank you very much. Appreciate that, and we too are very excited, and we hope that everyone on the phone today gets a lot out of today's discussion. And as Andy said, on the right-hand side of your screen there is a Q&A window, and if there are questions that come up, please put them into the window, and our folks behind the scenes will sort through them and pose them to our presenters as we go through here today. First thing we want to do is make sure that folks are completing the poll question. I believe it is open. The question is, have you had experience promoting health equity in the context of a needs assessment? If so, what type of an assessment? A community needs assessment, a community health needs assessment, some other type of needs assessment, or perhaps you've not had experience in that area. So if you could go ahead and click, if you have not already, on all that apply to you. And as we go, after we finish the bios here, we will come back and talk about the results of that polling. We have 3 dynamic speakers with us here today, very well experienced in today's topic. Our first speaker is Dr. Aaron Wicks. He is the Director of Planning and Evaluation for Action for a Better Community in Rochester, New York. He works with a staff of 4 in the areas of grant writing, advocacy, customer satisfaction, program monitoring and evaluation, and the development and implementation of the agency's strategic plan. He is a nationally certified trainer in the practices of result-oriented management and accountability, or ROMA, a management paradigm that guides the national network of community action agencies. He's also a certified community action professional, a distinction recognizing his management knowledge and skills in the field of anti-poverty. He is currently a member of a collaborative supporting the Facing Race, Embracing Equity initiative in Rochester. This initiative is intended to build community capacity around identifying and remedying the causes and impacts of structural racism. He holds a PhD in political science from the University of Rochester. He's going to provide us with an overview of community needs assessments that inform community services and benefits supported by programs administered by the Community Action Network. He'll also give us an overview of the range of community benefits and services that are oftentimes informed by these assessments. Our second presentation today will be delivered by Dr. Vincent Lufthansa and Dr. Steve Adini. Dr. Lufthansa is the President and Chief Executive Officer of the National Network of Public Health Institutes. He provides leadership and direction on all Institute initiatives and develops collaborative efforts with the Institute's numerous public health institutes and partners throughout the nation. Dedicated to the vision of improving public health through innovation, the Institute is the national member network committed to public health institutes, to promote, sustain, improved health and wellness for all. Beginning his career in Health and Human Services in 1985, Dr. Lufthansa has held health policy and programming positions in government, nonprofit, and university sectors to advance population health at multiple levels of intervention, including community, state, federal, national, and tribal spheres of influence. He holds a Doctorate of Adult Education, Master of Science, and a Certificate of Gerontology. He also completed an Oak Ridge Institute for Science and Engineering Postgraduate Research Fellowship in Public Health, as well as 2 Salzburg Fellowships focused on the social and economic determinants of public health. He is an active member of the American Public Health Association and serves on the Board of Directors for Education, Training, Research Associates. Dr. Stephen Rodini is the Vice President of the Community Health Division of HRIA. He brings 25-plus years experience working in public health within the U.S. and internationally. He has extensive experience in nonprofit management and administration with a professional background in spanning research and evaluation, strategic planning, and organizational development, grant writing, and coalition building. Dr. Rodini earned a bachelor's degree in biology and political science from Boston College, followed by a master's in public health and a doctorate in education, both from Harvard. He has served as a lecturer at Harvard and has authored 2 books on social change, Health and Sexuality, Education in Schools, The Process of Community Change, and Grassroots Social Action, Lessons in People Power Movement. Dr. Lufthansa and Rodini will tag team to provide us an overview of community health needs assessments, their purpose, structure, and process, share some core principles of equity that can be found in a community health assessment, highlight the importance of equity, certainly, in a needs assessment, highlight emerging drivers for anchoring the use of health equity lens in community health needs assessments, such as in the Public Health Accreditation Board assessments, and will highlight opportunities to integrate equity in hospital-driven community health needs assessments. Our closing remarks today will be offered by Seth Hassett. Seth Hassett is the Director of the Division of State Assistance within the Office of Community Services and the Administration for Children and Families. Major programs within the division include the Community Services Block Grant and the Social Services Block Grant, and Empowerment in Zones and in Enterprise Communities. In addition to coordinating large block grant programs, BSA supports specialized technical assistance and exemplary practice programs focused on areas such as benefit enrollment coordination, performance management, and leadership development for community service providers. Mr. Hassett is a social worker with experience in health and human service program administration, policy, budget, as well as community planning and service delivery. He'll be offering his perspective on the value add with improved coordination across assessments and, more importantly, among partners working together on health and the social determinants of health in communities. So you can hear that we have a number of highly experienced folks with us today, and I think what they're going to be able to bring to the table will really energize the folks on this phone and help us find new ways to work across sectors and work with each other. So I'm going to pause. Andy, if you could let us know what the results of the poll question were, and let folks know where the scores sat.
Yes, Denise, I can do that. So once again, the poll question was, have you had experience in promoting health equity in the context of a needs assessment? And if so, what type of assessment? What type of assessment? And our responses were, for A, community needs assessment, we had approximately, we had 53 respondents, and we'll verify the
about 11%.
11%. Thank you, Cashin. And if you could follow up with the additional percentages there, if you wouldn't mind.
Sure. I can go ahead and read those out to you. Community health needs assessment, and those were 26% of our respondents. Other types of need assessment at 9%, and no experience, we actually had 24% of our people no experience with needs assessment.
Okay, thank you, Cashin, for reading those off and helping us begin to frame our conversation today. Maybe we'll see some different scores if we take this poll question, let's say 2 years from now. Hopefully, if, our networks can work more closely together over time. So with that, Dr. Whip, I will turn this over to you to begin our presentation. Thank you. I don't believe we're hearing Dr. Wicks.
Hi. I think we reordered the order of the speakers. I think Steve is going to start.
Oh, my apologies.
With, some overview. No problem.
Actually, if you sent Vinny.
Okay.
Yes, we have this here for Steve Rodini. Mr. Rodini, can you take it away?
Yes, hi. I actually, I'm sorry, it was for Vinny Lufthansa who was going to start.
Vinny, okay. Mr. Lufthansa, we'll move this right down.
That's okay.
I'll bring you on here. Mr. Lufthansa, can you hear us?
Can you hear me now?
Yes, Mr. Lufthansa.
Okay, well, thank you very much for participating in today's webinar. And more importantly, thank you for the important work that you have underway in communities throughout the nation. It really is an honor to even be on the call today with all of you and to represent the National Network of Public Health Institutes, also known as NNPHI. During our time together today in this webinar, we will do our best to achieve the following 5 objectives, and it really is not unlike speed dating. As you know, there are thousands of community assessments conducted in communities across the U.S. on a periodic basis. Many of you do that work. We believe these processes and all of the partnering activity that is required to complete them provides a unique and important opportunity to advance our progress as a nation on closing avoidable and unnecessary inequities in health outcomes among populations. Yesterday at a national public health conference here in Atlanta, Dr. Tom Frieden, the head of CDC, challenged us in the field to do just that. NNPHI has many assets, and among them we have institutes with deep experience catalyzing innovation by designing and implementing multi-sector initiatives that leverage the strengths of government, nonprofit, university, and discipline-specific sector partners to produce measurable change in population health improvement. The institutes across the nation are expanding. And right now we have a growing network of 39 public health institutes working with programmatic activity in all 50 states. Another important strength relates to our feet on the street model with over 4,500 staff experts working closely with state and local governments, hospitals, hospital systems, CBOs, and other critical partners in health, some of you who are on the phone today. Each of the 39 institutes have varying capacity portfolios, and increasingly we are working to share capacities across institutes to maximize access to needed capacity. These core functional areas of expertise are paramount to community assessment and corresponding implementation work required from those assessments. Public health institutes are terrific local resources with national connectivity. As a network, we share best practices, stimulate and test innovation in multi-sector strategic collaboration to produce health and prevent infectious and chronic disease, and help build capacity of public health institute resources that are available to states, communities, and tribes. There are many definitions in the literature in use, and while no one set of definitions may work for all groups, we believe it is important for collaboratives to examine the assumptions of their approach. The community assessment process provides an opportunity for groups to identify and address important factors of disadvantage that are driving disparities, factors that are outside of individuals' control. Many community efforts intentionally avoid using the term equity to avoid political backlash. Greater equity can be achieved without equity as the banner. What remains important is the intentionality of the work and identifying drivers of disadvantage so that strategies can be designed specifically to address the disadvantages that cause the inequities. An important principle of equity work, and one that differentiates this approach from others, relates to removing obstacles present in our society that continue to disadvantage and therefore limit access to health-producing opportunities. Providing fresh fruits and vegetables to people living in a low-income neighborhood may be helpful and it may be a good example, but this effort alone does not address the inequity in the distribution and availability of health-producing assets associated with cost-effective food systems for all neighborhoods or cost-effective educational opportunities for all neighborhoods. So there's much more to do than a single intervention. So equity work frequently requires, therefore, a comprehensive approach that illuminates, examines, and removes barriers so that all communities, families, and individuals have the same access to health-producing assets. Behavior and choice do remain important drivers, but science clearly shows that zip code is a stronger predictor of life expectancy, and choice is heavily influenced by our environments and access to resources. Regardless of the political climate in a community, most every reasonable partner can agree that 3 core principles can in fact guide assessment activities. Eliminating all or any of these disadvantages will help everyone. Community health assessment efforts require purposeful framing, and it is critically important to consider the framework in very early stages of the work so one can avoid the process quickly moving down paths of remediation. It may be necessary to include some customary interventions, such as cooking classes, for example, in the health field, which may help achieve broader community engagement and interest, but at the same time, land use policies governing the number of fast food chains situated in a 3-mile radius of a high school, for example, will more likely be an important policy lever that can advance equity-based approaches. The recent examples of cities passing minimum wage increases and mandatory paid sick time are also very good examples of greater and lasting impacts because these efforts help to remove the obstacles to health and well-being over time. Community health assessment involves a regular and periodic systematic measurement of important information that drives health. Excuse me, we're having a hiccup here. What gets measured gets done and also can help eliminate drivers of disadvantage. Effective assessment processes leverage the strength of communities using asset-based approaches. There are many good reasons to conduct community health assessment. Right now we see both carrot and stick approaches in the use of them, as there are both incentives under the National Voluntary Public Health Accreditation Movement or the federal government in some instances requiring health assessments or community health assessments as part of, or community needs assessments as part of the usual business under the Affordable Care Act, and also to ensure federal qualified health centers are well positioned to serve their community service missions. So we have a lot of opportunity to use both the carrot and the stick. There are a myriad of other benefits not listed on the slides today, and these are all important opportunities to learn more about how we can create health in communities across the nation. And that's what our work will be about as we continue in this partnership. It is now my pleasure to pass the slide deck to my colleague, Aaron Wicks, who will share his deep experience with Community Action Partnership. I thank OMH for the opportunity for the speed dating, and I would love to set up more opportunities so that we can carve out specific areas of collaboration among community action agencies and our public health network.
Okay, thank you very much. Nice to be back. I apologize to the audience for the switcheroo there in terms of presentation, but I'm glad we're back on track. So many of you in the audience may be members of the Community Action Network, and so some of this is going to be very familiar to you. But for some of you, it may be less familiar, so I apologize if this is a little repetitive. But I just wanted to be sure that, that we have a common framework to understand where the Community Action Network fits in to this discussion, and why it's so important to us to be sponsoring this, this conversation. As Denise mentioned, we're a nationwide network of 1,000+ agencies across the United States. One of our main funding sources is the Community Services Block Grant, which we call CSBG. This is federal money that has been allocated in some form or another for the last 50 years since the War on Poverty was launched. But for the last 35 years, approximately, the money has been administered by state governments. So it's a federal pass-through through the states to local agencies. And this funding requires that these resources be used to focus on poverty, economic self-sufficiency, community linkages, and vulnerable populations such as children, youth, and seniors. One requirement of the Community Services Block Grant is the conduct of community needs assessments. And a complete community needs assessment must be completed every 3 years, and it must be updated each year. So, as I say, and when we talk about a carrot and stick approach, there is a mandate on community action agencies to conduct this assessment. But even if it weren't a mandate, it's obviously still an important best practice. because another mandate on community action agencies across the country is to leverage existing resources to address needs across multiple domains. We look at family-level needs, in other words, services for individuals. We look at agency-level or community capacity types of needs to determine where there are service gaps and where resources can be leveraged to make services more readily available to individuals with low incomes. And then we also look at community needs in terms of structural barriers that may make it difficult for some in the community to become more self-sufficient. So perhaps some resources are in low availability. Jobs may be scarce. Transportation resources may not be widely available. Those are community-level needs that we try to capture in our community assessment. Now, community action has been focusing more on issues of structure throughout its 50-year history. And particularly in the last several years, community action's been looking more at broader policy issues that impact barriers to self-sufficiency, issues of racial equity and racial disparities that result from inequities that are either institutional or structural in nature. Similar inequality issues around gender and other groups that are experiencing inequitable access to opportunities, and just disparities generally that result in the isolation of people with low incomes. Okay, sorry. Now, in addition to the community needs assessment requirement that community action has, many agencies, not all, but many community action agencies operate Head Start programs. Head Start also has a community assessment requirement, and that requirement overlaps very thoroughly with the requirement of CSBG, but obviously it's focusing a lot more on child and family needs, barriers to self-sufficiency of families, as well as inventorying, if that's the word, conducting an inventory of community resources, such as transportation, housing, health, nutrition, and other aspects of family life, literacy, availability of emergency resources, clothing, things like that. So when we think about this context, community action agencies' needs assessments provide excellent opportunities to bring stakeholders together to conduct the assessment, to engage residents and service providers through the process of the assessment, to demonstrate the interconnectedness of demographic patterns, behavioral patterns, and the resulting outcomes. So going beyond just a collection of data, but drawing the lines that connect the dots that help us understand why is poverty concentrated in some parts of the community? Why do some populations in the community have higher rates of poverty or child poverty? Why are barriers, why do they take on certain patterns? Our community assessments give us the important data to demonstrate that interconnectedness. And for a lot of community stakeholders, that interconnectedness is not always foremost on their mind. So it's a wonderful opportunity to make that present for them. And the community assessments also provide a common data set for policymakers and community stakeholders to establish community goals and develop strategies to address those disparities. So the community action needs assessment could become, or in some cases may already be, a yardstick for the community to say, where are we now? Where were we in the last 5 or 10 years? And what does that say about where we can go as we move forward as a community? Community action uses a planning process called ROMA, and I will use the next 72 hours to provide an overview of how Roma works. I'm not hearing any laughter, but I'm hoping there's a little bit, maybe some groaning. Now, I just wanted to mention, for those that aren't familiar with the Community Action Network and Roma, that Roma is just the planning process that we use. And you can see it's a process that's common to other organizations or institutions. An assessment being the starting point or the foundation, that leading to planning, the implementation of the plan, the monitoring of results, and then the evaluation of those results, feeding the next assessment. So it's a fairly common pattern, but I just wanted to be sure that everyone participating was aware that community action does have that planning process, and that the community assessment fits into the process in that way. So now I just want to provide some concrete examples. Again, some may be familiar with these, some may not be, but these illustrate just some of the ways that community action uses data in community assessments. The Community Action Partnership has an online assessment tool which allows communities to readily access the most recent census data on a variety of measures relevant to that community. So here we have data about nutrition, and in particular households that are receiving SNAP, or formerly called food stamps. So that gives us some information about the degree of need in the community, and particularly for community action agencies that are serving broader areas, multi-county areas, or even entire states. This information is helpful to show geographic patterns that often overlap with patterns of disparities by racial or ethnic groups because of segregated housing patterns that are quite common across the country. And then the tool also provides the data in tabular format, broken out by region, in this case also by age, so that one can drill down a little further and use the information at that level. Now, another example that I wanted to provide of how community assessments can be used, and this gets us a little more in the direction of our topic today, is how ABC, Action for a Better Community, is using community assessment data here in the Rochester area in upstate New York. We're the backbone supporting organization for an initiative called Facing Race, Embracing Equity. And that initiative is looking at structural racism across multiple areas. One of those areas is healthcare. And we have a wealth of resources in our community dedicated to focusing on such disparities. So we're quite lucky to have other nonprofits as well as government agencies that are focusing resources on health disparities by race and ethnicity. We have incorporated that information into our community assessment because it connects so directly to other disparities that our organization is interested in focusing on, both through the Facing Race, Embracing Equity initiative, as well as through our mission here in the community to be an anti-poverty catalyst. So a little bit just about how we do our community assessment, or how it's been used. Just an example, I won't go through our whole process. Those stakeholders who contributed to the development of our assessment, we shared the assessment with them. Our assessment, our full assessment, is over 200 pages of charts and graphs. And as a courtesy to those who helped us provide that information, we share it with them so that they can have the information. One of the parties that we shared it with was our local Department of Human Services. We were recently informed that they used the data in our community assessment to do some of their own planning. And in our most recent assessment, we conducted a survey of DHS county level DHS staff to find out their attitudes about what's going on in the community, what the barriers are. And that was information that they themselves didn't previously have. So they found the assessment helpful. And I think this is an example of how when you're bringing stakeholders in to the assessment process, you can have more of an impact with the final result. I see a question that asks if the assessment is 200 pages or is it the results, and how many questions or queries do we have? Just as a sort of a side note, our assessment document is over 200 pages. It's a mixture of charts and graphs, narrative, summaries of survey results, etc. So we combine information from the assessment tool that I mentioned earlier, as well as other data that we collect from other sources. So I was referring to our full document. I'd be happy to share that with anyone that has a problem with insomnia or would be interested in seeing what's in our assessment. One last example that I just want to provide before I turn the microphone over is how our assessment can translate into action directly. In our community needs assessment, we identified that youth violence was a very prominently emerging concern. And the excerpt that we have here is straight out of our assessment. Homicide is the leading cause of death among city youth, and the second leading cause countywide. And unfortunately, I think that's a fairly common phenomenon across the country. But we also identified some long-term trended data from our county and our city law enforcement sources. And then for our assessment, we drilled down a little bit more to look at the nature of the crime, who is committing the crime, who is involved in the crime, both as perpetrators and victims. And obviously, we discovered that there was a significantly disproportionate number of males, and particularly males of color, that were involved on both sides as both perpetrators of violent crime as well as victims. And so here's just some tabular data that also captured that. You can see that the city of Rochester is clearly where a disproportionate number of violent crimes as well as property crimes are committed. And again, because of patterns of housing, a disproportionate number of those crimes involve people of color. So this gave us some pretty good documentation of disparities in the area of crime and criminal justice. We also combined information from a survey of neighbors that basically reinforced some of those findings. Neighborhood issues, crime issues, abandoned properties, all of this fairly interconnected. We used that information to move to action, and we launched an evidence-based anti-violence program, jumped ahead there, called Cure Violence that is from Chicago, and we're just implementing it now, so I can't give you any results at this point. But the point that I wanted to make with that example is that here was a community assessment that brought together stakeholders, identified an emerging need, and then somewhat fortuitously connected to funding that was made available by New York State to address that need. And with the research that's going on at the national level and the funding that hopefully will continue to be available in the coming years, we feel that the Community Action Network is a logical catalyst to bring together community stakeholders around issues of health disparities to not only gather information, but to identify the emerging trends and then to take that next step to plan responses. And so I think this is a wonderful opportunity for our network to help fulfill its mission and leverage the existing resources that we have, build partnerships, and extend opportunity across some of those barriers that have kept some out of accessing opportunity. So that's my part of the presentation. I'd like to turn over to Steve, I believe, who will be presenting next.
Great. Thanks, Aaron. I just wanted to also say thank you for everyone for allowing us to present today. Again, as Denise mentioned, my name is Steve Rodini. I work at Health Resources in Action in Boston, and we're part of the National Network of Public Health Institutes. And over the past few years, we've worked with communities and multi-sector partnerships around the country to conduct approximately 50 community health assessments and health improvement plans. And what I wanted to do was build on what Vinny and Aaron were talking about, because what we're finding is through this work, we're working with partners to intentionally integrate a health equity frame within this work. And as Anya Michi said in the very beginning, this is really an opportunity to think about alignment. So the slide in front of you is really thinking about all the different things that are currently happening in community around these areas of assessment. So if you look at the top, you could see community action agencies and partnerships, hospitals, health departments, United Ways, financial institutions, community health centers are all doing some type of assessment, either based on mandates or strong recommendations to do these types of assessments. So we're at a wonderful time in work in community to think about how we may be able to partner with other entities within community who are also doing these assessments, whether they be every 3 years or every 5 years. So one piece of advice I think we'd like to share with you is get to know who else in your community from the hospital or the United Way or a health department or a community health center is doing this type of assessment, and figure out ways to partner with them so that we're not doing things in duplication, but we could work collaboratively. And if we move to the next slide, what I wanted to share with you is kind of thinking about a community improvement process, or from the lens of how we do this work from a public health perspective, is thinking about this from a community health improvement process, where we go from assessment to planning to implementation and monitoring and evaluation. All of this based on kind of a collective vision of the community, that if this happens well in terms of engaging the broader community and stakeholders, and this work is effective, that we could ultimately see improved outcomes, and in this case, in particular, improved health outcomes. Again, as I mentioned earlier, what we're looking at is ways that we can infuse a health equity lens into each of these stages of the process, as well as also thinking about the social determinants of health, whether we think about housing information, education information, economic data, job data, transportation data, all of those things that make a community healthier. So as we move to the next slide, what I wanted to do is kind of just share with you in each of these areas, how are we infusing or thinking about intentionally integrating a health equity lens? And so part of the questions I put before you are things for you to think about with your respective teams as to how you're thinking about health equity. And again, this is not an exhaustive list, but it is the beginnings of some questions and conversations to have at the local level. So does your community improvement plan have a vision? And is your vision inclusive of all members of the community and not just the folks that are coming to the table? When we move to assessment, how are you engaging the community in data gathering? What data are you gathering, both quantitatively in terms of the numbers, and then also qualitatively in terms of the stories that provide a context in how community members live day to day in their community? What types of indicators are you using to understand health equity, or really health inequities, and who's most impacted by these health inequities, and who are the vulnerable populations within the community? So again, these are questions are really meant to be guiding questions for you as you go through each phase of this process. When we think about planning, who are you engaging to prioritize your data findings? Is this being done with community resident participation? Is it being done with professionals and providers? What kinds of criteria are you using to prioritize the data, and are you using health equity as a criterion? What equity issues are you addressing through a proposed strategy and approach, and who's intended to benefit and how? And then what types of strategies and policies, either currently or what you're proposing, support healthy choices, and what strategies and policies are barriers to healthy choices? And how does the proposed strategy expand opportunity and access for all people in the community? And how are you engaging the community in identifying and selecting strategies and policies that support healthy choices for all? As we think about the area of implementation, how are you engaging the community in strategy implementation? Who is and how are you defining success? So is the definition of success basically providers making that decision, or are you engaging the community in that process? Who is holding individuals and agencies accountable for their efforts? What types of community assets can you build upon for effective implementation? And then what kinds of what community and institutional practice may be either support or hinder achieving equity? And then finally, in the final area around monitoring and evaluation, how are you engaging the community in monitoring and evaluation? What types of outcomes and metrics have you established? Has equity been considered in developing these outcomes and metrics? What is the impact of efforts on vulnerable populations in your community? And who's involved in determining the impact? And who and how are results being communicated back to the community, and how often? And then real briefly, before I wrap up, I just wanted to share a quick case study in Worcester, Mass, where about 1.5 years ago, we worked with the community there, with the hospitals, the health centers, the health departments, the United Ways, community-based organizations and partnerships, and local foundations to actually conduct one assessment for the city and the surrounding communities of the greater Worcester area. And they formed a 20-member advisory committee. We conducted key informant interviews and focus groups and discussion groups and a community survey. We were able to actually gather data from approximately 1,700 people in the area, and then engaged about 150 providers and community residents in a 2-day rapid strategic planning process. And I share this because the next slide is one of the priority areas that was identified by the group. So there were 5 priority areas. One area was substance abuse, a second area was healthy eating and active living, a third area was mental and behavioral health, and a fourth area was violence and injury prevention. And the fifth area, as we began to have these conversations with the broader community and the providers, was a real need to identify health equity as a priority. So this was the 5th priority identified by this group of 150 people and presented to the city manager and the mayor of the city of Worcester. And as you can see, the goal for health equity was to improve population health by systemically eliminating institutional racism and the pathology of oppression and discrimination by promoting equitable access to and use of community resources. And over the period of 2 days, we began to develop a set of objectives where we would look at modifying 2 city-level public health policies that contribute to health equity, enhancing the capacity of 100 grassroots leaders to effectively influence the development of policies that address health disparity and promote health equity. And of those 100 grassroots leaders, 25 of them would be youth leaders in the community. And then in the third objective, to enhance the capacity and will of 20 cross-sector institutions to address and eliminate institutional racism within their own agency. So this, as you can imagine, is some powerful language being used by this community, one in terms of what they identified in terms of the disparities through the data gathering through the assessment process, and kind of an empowering piece over this 2 days of looking at this data and coming up with a health improvement plan for the city and the surrounding community, really elevating health equity up to a major priority in the community. And then finally, I won't go through the detail here, but this is a little bit more information about the strategies, the timeline, the partners and resources to move the agenda, and some very specific outcome indicators that we'll use to determine if we've actually met those targets to address health equity. So those are some of the things I wanted to share with you today, and that concludes my part of the presentation. So thank you.
Thank you very much, Dr. Adini. And now we'll move on to the question and answer part of our session. I've received a fair amount of questions, so I'll go ahead and start off with the first one. Dr. Rodini, Dr. Wicks, and Dr. Lufthansa, you guys are all unmuted. And I'll go, some of the questions are a bit more specific, and with those, I'll go ahead and try and direct those directly to a specific speaker. The more general ones, I'll just say it's general and let either one of you guys decide who will answer it from there. And this first one does appear to be a bit more general, although I think it might fit better under Dr. Wick's purview. The question is, can you give examples of communities that have established common data sets for policymakers and stakeholders? This is a challenge in our state of New Jersey.
I can. I can't give you a comprehensive list of them, certainly. But I can just give you an illustration, and that could give you a place to look for examples. Here in Rochester, our local community foundation supports a program called ACT Rochester. And ACT Rochester is basically a convener of community stakeholders for really the main purpose of identifying community indicators and then reporting out on them each year so that we can track our progress. So it's a resource that exists for others to take advantage of. It doesn't have responsibility as such to do planning, but it provides a common sort of data bank for anyone in the community to see where are we as a community, in areas of crime, the economy, the arts, health, education, you name it. I'm also aware of a similar community indicator program in Savannah, Georgia. I think it's Savannah, called Step Up Savannah. So I know that these types of community indicators exist in multiple communities. And I would just suggest doing some research around community indicators, checking out the ACT Rochester website, just to get some thoughts about how community assessment data could be pooled together to provide a common framework of indicators for all stakeholders to use.
Could I add to that, Aaron, in terms of, because I thank you for that information, and I think it's a great question. One place where you might find some common data sets is at the national level through Community Health Needs Assessment, or chna.org. It's a site that's co-sponsored by folks at the federal level from the Centers for Disease Control and Prevention. So that's a great resource to folks. And in particular, in New Jersey, for the person asking the question, I might get in touch with the folks from the Robert Wood Johnson Foundation. They have funded 7 or 9 multi-sector community partnerships over the last few years to actually do this work, and they are at different levels of kind of pooling this data. So I'd be happy to get you in touch with the right person, but the Robert Wood Johnson Foundation is funding these multi-sector partnerships in New Jersey to do that.
Okay. It sounds as if Dr. LaFranca, would you like to add anything, or would we like to move on to the next question?
I think that's perfect. We can go on.
Great, great. The next question sounds to me to be more of a general one. It is, what are the frequencies of community needs assessments? Is the process coordinated with hospitals, local health departments, and local health departments? And this sounds as if it's kind of just a recap of what we've done before, but whoever would like to start can certainly do that. It might be a good idea if Dr. Rodini starts off with that question, then they can, if Dr. Wicks or Dr. LaFrance would like to add, they can go ahead and do that.
Sure. So Andy, could I just ask for clarification? So it's about what is the process?
Is the process coordinated with hospitals and local health departments?
I see. That's a great question. So if we go back to that slide that I had with all the circles, in the best case scenario in places like San Antonio and Worcester and El Paso, and I'm sure there are many other places, these efforts are being coordinated with visionary leaders from hospitals, community action agencies and partnerships and hospitals, United Ways and other areas. But I've also got to say, what we're also finding is in some communities these efforts are happening simultaneously or duplicative. So one of the best things to do in your own community is to get in touch with your hospital. In fact, hospitals, nonprofit hospitals, will be going through this process again in 2015, or your local or county health department, to figure out where they are at in this process and begin that conversation of where you might be able to help them or assist them with their efforts. So this is a great time to begin thinking about those conversations and really enable us to move from duplicative efforts to more concerted and collaborative efforts.
Steve, I will also add a lot of the communities that we've worked with in the past and a lot of the institutes across the country are working with have very specific steering committees, and some of them are actually chaired by local elected officials, and they are inviting specifically on the steering committees, you know, the hospital, health department, school system, you know, you name it, a whole host of agencies. And those processes in some cases are actually being evaluated, and so it is an effective way to ensure that independent assessments don't sit on shelves. And the timing of the frequency, I think that was part of the question, is generally a 3-year cycle, and we're about to start a new cycle in 2015. So in terms of the hospital side requirement, that's not for the community needs assessment requirement, but it does make a lot of sense to put steering committees together so that we don't have independent data sitting on shelves that really aren't going to be helpful in terms of addressing equity.
Yeah. Great, thank you very much. The next question is, and this one I think is would be better directed to, at least to Dr. Wicks right off the bat. And the question is, what is the Concerned Neighbor Survey, and can the survey be shared?
I'm sorry, I missed the second part of that. What's the Concerned Neighbor Survey?
Yeah, what is the Concerned Neighbor Survey, and can the surveys be shared?
Yes. Yes, we'd be happy to share it. The survey is, well, we actually did a couple of different ones. We have a community building program that maintains a list of active residents, active in neighborhood groups, and things like that. And so we used SurveyMonkey to send a brief survey to those residents to ask them about some of the leading concerns that they have in their neighborhood. In parallel, we also did just a broader resident survey that was more comprehensive, and that was a paper survey of several pages. And I'd be happy to share both of those. It's important. I want to say very clearly, it's important when doing surveys like that to pay a lot of attention to the survey mode. We found that literacy, as well as modality, like who's providing the survey or how it is provided, can have a very significant impact on participation and the quality of the results. So when we're looking at disparities and different populations where language might be an issue, or there might be other issues, you just need to be cognizant of those. But I'd be happy to share anything that we have.
Great, Aaron. Thank you very much. So our next question is a bit longer than the other ones. It actually contains about, I guess, 4 sub-questions. So, and I think, Dr. Rodini, it'd be best for you to start off with it. So let me just kind of read the question, then you can come back for some clarification if you need. So first is, when must the community health needs assessment be initiated? How many years does it cover? Within a state, do all agencies conduct their community needs assessment at the same time? And is it aligned with other community assessments, such as area aging centers and FQHCs, which are also required to assess? And some of this you might have already covered, but we'll go ahead and go from there.
That's okay. I think, again, it's a great question. And just to answer that real briefly, is health departments, if they're interested in accreditation through the Centers for Disease Control and Prevention, will be doing an assessment and a plan every 5 years. Hospitals, to maintain their nonprofit status and to meet IRS guidelines, nonprofit hospitals will do these assessments and these plans every 3 years. And federally qualified health centers, through HRSA requirements, will do these plans every few years as well as HRSA guidelines. I'm sure there are other requirements in there through the Community Investment Act and through the Community Action partnerships in terms of I think those are done every 3 years as well. Again, I think it really varies from one community to the next in terms of who is leading these efforts in the community and the visionary leadership and the collaborative leadership that's needed to ensure that these are happening collaboratively. And we've got quite a few sites. In fact, the National Network of Public Health Institutes on their website has some of those examples where this collaboration is happening across these different entities. And in the next rounds of assessments in 2015, we're looking, part of this conversation is to promote more of that collaboration across these entities in terms of looking at doing joint assessment and planning, and then really more importantly, moving out of the assessment and planning realm and really getting into implementation and looking at resources for implementation and measuring impact.
Dr. LaFrance, Dr. Wicks, would you like to add anything?
I think Steve did a great job.
Right. Yeah, I agree. I have nothing to add to that.
Okay, let's move on to our next question then. This one, I think, Dr. LaFrance, you might be able to start off with. Have any of you worked with the area agencies on aging who are doing needs assessments across the country or related to older populations?
Yeah, that's also a very good question. We are not tracking that, but there are some examples embedded in the community health needs assessment process in those communities where there are broad coalitions, and I couldn't even name them all. But that is another area and a great partner, particularly given the demographic shifts that we're experiencing, a great partner to engage. I don't know, Steve, if you have specific examples in the sites that you've worked in. In some of the sites that I worked in, we were keeping the community area aging up to speed on what we were doing, but they weren't actually involved heavily in the process, but we really wanted to see more of that.
We are beginning to see some of that collaboration in Massachusetts and in southern Vermont, but it's a great opportunity to see more of that collaboration happening.
And Dr. Wicks, anything to add?
We have not done a lot of explicit collaboration with our local Office on the Aging, but we have been working closely with a number of county agencies, and so I think that's a natural step in the evolution. I think it's a good point to keep in front of us.
Excellent. Okay, so the next question I think Dr. Adini can start off with. What role do you think a state health department can play for a local community health needs assessments? Also, these assessments are mandatory, but implementation of results is not mandatory. How have folks worked with hospitals to get them to implement projects addressing results from the community health needs assessments?
Great question. A few things. There are many state health departments that are now undergoing this assessment and planning process through what they call a state health assessment and a state health improvement plan, or a SHA and a SHIP. And I think right now there may be about a handful of states that have actually gone through the accreditation process. And I also know we're working with quite a few states right now on this very process. And again, in the best case scenarios, these state level of assessments, folks at the state level are gathering the assessments at the local level to see how we could align efforts with local efforts, and then also really think about what may be going on at a state level and to see how local efforts can enhance what the state finds. So I think there's a lot of opportunity to think about alignment with state health assessments and state health improvement plans, which is very exciting. Again, I would encourage the person who asked the question and others on the call to be in touch with your local, your state health department to figure out where they're at in the process. Because again, some have been accredited, some are going through this process right now. But interestingly enough, I think in time what you'll see is more state health departments looking at aligning their resources from private philanthropy and public dollars around these assessments.
Steve, that was great. I would just add that while the states are undergoing through the public health accreditation process, in some of the more rural, or states with more rural communities, some of the states actually have a lot of service delivery roles in communities, and also capacity building roles in communities where you may not have, you may have very small health departments that are trying to do all of this work in collaboration with hospitals as well. So it makes sense for the state government to have a very important, both in terms of policy and capacity development and training, and then sharing the learning. So there's a lot of statewide collaboratives that are meeting to talk about what they're learning across the state on the different assessments. And there are also some areas that are beginning to say, let's try to do a regional assessment instead of just our own independent community, especially in the rural areas where there might be more regional issues that could be addressed better.
Okay, so our next question, I guess, is really more of a comment than a question, and perhaps either Steve or Aaron or Dr. Adini, Dr. Wicks, or Dr. Lufthansa might want to just simply comment on this. Basically, the comment is this. I know in Oregon with the CCO and the requirements for all the CCOs, specifically the community action councils, really need support for community health need, for CHAs or community health assessments, and the follow-up community health innovation plans. Many smaller communities are not as prepared for this type of work, nor are they staffed. Perhaps you could speak to the possible staffing issues or the possible resource problems that might present themselves in trying to implement these types of action plans, or excuse me, these types of needs assessments.
So I'd like to address that because I want to concede something right off the bat. My role here at Action for a Better Community is the Director of Planning and Evaluation. So we actually have in our agency a department with 4 staff that spends a significant amount of time doing these assessments. So I know the resources that are needed to do that, and I think that's a major issue that affects virtually every community, because very few agencies and very few communities have the resources, have people in staff positions to devote the time that's needed to do the types of assessments. So I think funders and service providers and other community stakeholders need to have an honest conversation about making sure that we have adequate resources to do the baseline assessments that we need, so that we can then allocate other resources effectively. It's an extremely important issue.
Okay. We can move on to the next question here, and this question is focused more toward health departments, and basically it is a local health department. Told me that they had nothing more recent than a 2000 community health assessment. How do you suggest interpreting that? Is it a rural county with no United Way, or part-time LHD staff? And Dr. Adini, I guess if you'd like to begin with that, that would be good.
So the assessment goes back to 2000?
Nothing more recent than 2000.
2000. So this sometimes is not uncommon. Going back to this idea of resource allocation, Again, for health departments, this is not a requirement at this point in time, but it's a strong recommendation to think about accreditation. So the best thing probably to think about is in this particular area is to sit down with the health department and get a sense of where they'd like to go moving forward, and then what kind of resources they have and what kind of resources you may have to offer. At the same time, I would think about engaging the nonprofit hospital that is in that area, because they will have to have something that's later than a 2000 assessment, and have a conversation with them in terms of what they've done to meet the guidelines the last time and what they're thinking about for 2015. Again, we in the field, we have seen a range of assessments going that far back. Again, sometimes it's a resource allocation issue, or in most cases it is a resource allocation issue, whether it's funding or staff. So this may be a great opportunity for that person to talk to folks at the health department about how they could work together and maybe access private dollars or public dollars to make this happen.
Yeah, Steve, I would just add to that as well that, you know, if it's back to 2000, the 2015 cycle is coming upon us for the hospitals. And depending on the state that the question is coming from, there may be some local community foundations that may be very interested in also contributing. We've seen that happen a lot where there's multiple contributors to a process. And we have, part of the National Network of Public Health Institutes does have a group of experts at different institutes that are doing, as Steve is one great example, are doing community health assessments and TA in communities. And so if there's anything that NNPHI member institutes could do, you could look at our website, our map, or contact us, and we can put you in touch with some people that may be able to help you think through some resource development.
Great idea.
Excellent. So we're going to keep on moving with just a couple more questions and then begin to wrap up. I'd like to just continue with this one, and this can I would assume Dr. Witz could begin, and then Dr. Lufthansa and Dr. Adini can chime in afterwards. How do organizations track their community health needs improvements internally, and do health systems use work plans?
I'm sorry, can you repeat the first part of that again, please?
Sure. How do organizations track their community health needs improvements internally, and do health systems use work plans? And perhaps that's a better question for Dr. Rodini to begin with.
Yeah, I think that's going to be more on the health public health side.
Dr. Lufthansa, can you go ahead and possibly field that question for us?
Yeah, I'll get started. It's a very good question and a difficult one. Probably that's why we're pausing. Every community tracks their process a little bit differently, but in the assessment models that Steve had presented, you know, it is a cycle, and so part of that tracking is I mean, key to good public health practice is that you're going to be monitoring changes in the environment and what you're implementing, and in those cyclical processes, the work group or the steering committee should be coming back to whatever data are becoming available and monitoring that over time. For the needs assessment piece, I'm not sure that I could answer that in terms of community health or community action agencies, but I'm sure others can on the call. I just think that every community is doing it a little bit differently, but what's important is that you have data feedback loops in your process so that you don't end up 3 years down the road, you know, addressing things that are no longer priorities.
Excellent. Well, I think this has been an exceptionally fruitful conversation, and I look forward to seeing how this develops over time. I'd like to go ahead and just kind of wrap up the question and answer session and turn it over to Seth Hassett from the Office of Community Services for some closing remarks. Please note that we will be sending out the PowerPoint presentation or making that available. So anybody that would like that, the PowerPoint presentation will be available. We'll be sending out information on how to access that. Additionally, the webinar will be recorded, so anybody that has missed it or would like to access it again at a different time will have the option to do that. And we will be taking the rest, because there are a few more questions that we didn't get to. We're going to go ahead and take those questions and see about how we can put together possibly a document, a follow-up document with answers to those questions that everybody can share so that we can ensure that everybody gets kind of the gets all their questions answered. And with that being said, Seth, would you like to take it?
Okay, sure. Thank you very much, and just thank you very much to Office of Minority Health and Community Action Partnership for partnership in this webinar. And I think we've had just sort of the beginning of a really important discussion. As we heard, we began to scratch the surface of the complexity that comes with trying to align or coordinate our community needs assessments or community assessment efforts. We know that, as we all know, multiple federal programs require some form of community assessment. They may be more or less prescriptive in terms of their requirements, timelines, and certainly within the Community Services Block Grant, which we support, we think this is one of the more flexible areas for needs assessment, and so it is a place where there may be some opportunities to combine information from a variety of sectors and think comprehensively about the needs in communities. Dr. Wicks talked about our results-oriented management and accountability cycle, and we have different lingo in different fields, but really we're talking about the basics of a performance management system using needs assessment and community assessment data to guide our planning and strategic use of resources in our communities, and then, of course, having a cycle to assess our effectiveness and then use that data in the next round of community assessment and looking at our systems and changing community needs. So in every community, the situation is different, the level of collaboration is different, but a first step is always to share information about what kinds of assessments are required, and in some cases you may find that although there are very different formats and timelines, a lot of the same data may be and information and input may be useful for a variety of types of needs assessment. And ultimately, we hope, of course, that community assessments will be owned by the community, and that certainly those partners that are from the community, the United Ways, the philanthropic organizations that were mentioned earlier, they really are an important partner to help make sure that it is the needs assessment and community assessment is there for the community, not necessarily just to feed the requirements from a federal or state program. So our sense is that partnership can only strengthen both the needs assessment and really be the first step in further partnership. And we certainly hope this session will stimulate additional discussions and looking at ways to keep our responsiveness going to community needs. We have in community action, we know there's a 50-year legacy of services and activities, but community assessment is really how to keep it fresh, responsive, and dynamic in terms of addressing, partnerships and community needs that are facing us today. So with that, I think we thank you for our opportunity here, and would hand it back over to.
Yeah, thank you, Seth. Appreciate it. So I'd like to just kind of end with just a couple of quick reminders. Once again, thanks for joining us today. As was mentioned earlier, you'll be immediately directed to an evaluation at the conclusion of today's webinar. Can you just please take a few minutes to complete our survey, as it provides us with useful information about this webinar and the follow-up steps to the webinar. I would also like to thank the National Network for Public Health Institutes and the National Partnership to End Health Disparities for co-hosting the webinar. And finally, as I've mentioned before, a recording of today's webinar will be available on the Community Action Partnership website within the next few days. We hope that this webinar inspires you to think about ways to improve coordination between groups that are charged with providing community benefits and services. Thank you, everyone, and enjoy the rest of your day.